And today is a little bit different. We try to move and include more people in ISPN. The nursing symposium is quite new online, is the first one. Will be recording and available 24 hours a day on the ISPN website. We encourage all of you to join us to see this webinar. To participate, we have a chat box open during all the lectures, and you can do your questions. And at the end, if we have time, you can even raise your hands and try to talk with us directly. And thank you very much for all the speakers, for those that are with us, Katie, and especially Jeannie, that prepared all this webinar on the last months, do her best. For sure, we will have a lot of input for all of us during this 2 hours time. Please welcome some words from Jeffrey. After Jeannie will introduce how this webinar will be run, and Nor Maria introduce the speakers. Thank you very much. I'm grateful to be with you all. Thank you. And thanks for coming, Jeffrey. I know you are well committed, like Linda, traveling and do her best to be with us. It's really a privilege to work with you all. Welcome.
I couldn't agree more, Nelsie. You're a tremendous partner, and it's been a great partnership. I'm going to be very brief, other than to say how excited I am that people like Jenny and her team have put together such a great program for nursing. This is a new domain and direction for us. We have a large number of people registered and attending. I do want to give a brief call out to the ISPN guide as a reference. You don't have to be a neurosurgeon to call it up. It's available on the ISPN website. It is undergoing active updating, review, new chapters. So anyone who looks after children with pediatric neurosurgical needs can find explanations there from very good people, and that's a resource that we try to make available and try to encourage people to use. It's going to keep getting better and better and better. One of our senior leaders, Rick Abbott, is coaching and coaxing us all to get our chapters in and get things going. It is a very useful resource, absolutely free, ISPN guide. With that, I'll turn it over to Nor Maria or Jenny, whomever is next for the first phase of the program.
Thank you very, very much for having me with us today. It is a pleasure to be a part of this wonderful course, and especially today for this one-of-a-kind type of webinar, which is really important. Like I would like to say here, then when we talk about nurses, we consider everyone to be a Florence Nightingale, and it always, it's a very close collaboration between neurosurgeons and the nurses, and it is always a hand-in-hand collaboration which allows the provision of the best healthcare to patients and make nurses the integral part of all specialties, but especially in neurosurgery, where our patients need a lot of dedicated high level of care. So it's a huge salute to all the nurses who have made it possible for all the neurosurgical patients to recover in the best possible manner. So again, thank you very much. And I'm pleased to introduce the first speaker of this webinar, which is Ms. Jenny. She's the chair of the nursing section of the ISPN at present, and she's currently a movement disorder nurse and international rehabilitation coordinator at Sidra Medical complex in Doha, Qatar. And previously, she has a whopping experience of 35 years in nursing and advanced practice experience in Bristol, UK, working at Frenchay Hospital and Bristol Royal Hospital for sick children. So it's a pleasure to have her here today. She will be talking to us about the anatomy and physiology of the brain and spine and the CSF. So Jenny, welcome to the webinar. Thanks for joining us today.
Thank you so much, Nor. I hope everybody can hear me. As Nor said, I am the present chair of the nursing committee in the ISPN. We are trying to get ourselves up and running again, and I've got a great committee who are working with me, and this is one of the first things that we've brought. So I'm really excited and very privileged to be a part of this. Very happy to receive feedback at the end. There will be, I think there's be some MCQs at the end, but you could also leave some feedback for us. It would be very useful for me to understand if we have pitched this right, if we're talking about the right sort of things, and what else you would like, because we'd love to do another one of these either later this year or the beginning of next year. So the idea of today is there will be some anatomy and physiology. I'm going to talk extremely fast on the brain because I've got 25 minutes to cover the whole thing. So get your running shoes ready. Then Kathy is going to talk about cranial nerves and Ashley is going to talk about spinal nerves. After we've done that, we thought we would just have a little bit of fun. And we want to look at some questions around what makes a good neurosurgical nurse. What makes a good neurosurgical nurse for nurses, for doctors, in OR, on the ward, in PICU. We got a few pre-recorded videos that people have done with their own surgeons. So, and I would love to get a discussion going where people can tap into the chat and talk about what they think makes a good neurosurgical nurse, whether the doctors have got it right, and how we actually bridge between medicine and the patients that we have. So that's coming up later. I am now going to share my screen. Is that right, Linda?
Yes, you can share.
Oh, trying.
Little green box down at the bottom.
Yeah, I tried that. It doesn't want to come up. Oh, how strange. Share screen. It's on there. There we go.
There you go.
See.
Give it a moment.
So, yeah, we're there, I think. Okay, can everybody see it? Fabulous. So the brain, a lightning quick tour of the major sites. This is going to be very quick and it's not in a lot of depth because when you actually look at it, it's quite a lot housed in your skull. So we're going to whip around the cerebral lobes, the diencephalon, the vasculature and circulation, the blood-brain barrier, CSF, meninges, brainstem, and cerebellum. Stay with me. I thought we'd start with some interesting facts just to get us going. So a healthy adult brain weighs 1,400 grams. This is 2.5% of your total body weight. And blood goes in at 750 mils a minute. It's a vascular area. And brain information travels along the neurons at 268 miles an hour. That's faster than a jet engine and your big airplane. So it's going very fast. And we have as many as 86 billion neurons connecting to many, many other of each other, giving upwards of 1,000 trillion connections. That is brain-boggling to me. It is the fattiest organ. So 60% of your brain's weight is fat. Dear God, now we can all be fat heads. And if you can harness the electrical power in your brain, you can actually light a small light bulb. Successful neurosurgery has been documented from the Stone Age onwards. So it's been around for a while. And your brain can work extremely fast. So with 30 nanoseconds of information, it can build a picture for you to see. These are some of the facts about our brain that make my brain boggle. So let's go down and cut it into little pieces. So the brain can be separated into three parts. You've got your forebrain, your midbrain, and your hindbrain, as we all know. The forebrain consists of the two cerebral hemispheres, 4 lobes in each side, as we know, and connected with the thalamus, the hypothalamus, and the limbic center in the middle. And this is the largest part of your brain. The midbrain connects the fore and hindbrains together, and the hindbrain consists of your medulla, your pons, and your cerebellum. There we have the lobes of the brain, front at the back, parietal, occipital, temporal. So what do they all do? In the frontal lobe, it's the largest of your cerebral lobe, and you find it at the front here. It houses our primary motor cortex, which is found at the back of your frontal lobe. And also, your frontal lobe regulates reward and motivation. Obviously, my frontal lobe was working very hard whilst I was doing this presentation to reward and motivate myself to keep going. It regulates our behavior and our decision-making and our executive functioning. And it helps us predict consequences of action. So had I not completed my talk, I would have been embarrassed. So that was my consequence of action. It processes memories derived from the limbic system, and it helps with our impulse control, so addiction, aggressive behaviors, and socially acceptable inappropriate choices. You'll notice that the motor cortex is split into little pieces, as we know. What interests me when I look at this is look at the hand and the fingers. So each finger is bigger than the whole of your shoulder or your trunk. This is how much fine motor goes on in our fingers. And dear God, look at the lips. What do we do with our lips that needs such a big amount of brain space? Your frontal lobe is your last lobe to mature, and actually the final maturation of your frontal lobe doesn't happen until you're 20 or 25 years, and therefore your frontal lobe with all of that behavior and all of that executive functioning is so vulnerable to childhood and adult problems, drugs, TBI, environment, smoking, that you can cause trouble before it's even matured. So it also regulates attention. Hopefully everybody's frontal lobe is still working. You're all attending to me. And it assesses similarities between and differences between objects and people. It works along with your temporal and parietal lobes in recognizing different people's faces, so I can tell the difference between Nelsie and Jeffrey and not get them mixed up. Empathy may also drive from the frontal lobe, although we think it also comes from the limbic lobe. And most people's frontal lobe decreases by 0.5 to 1% each year after we get to 60. Not long for me. Moving on to the temporal lobe, key role in auditory processing. So you're all using your temporal lobes as you listen to me battle on now. It perceives sounds and gives meaning to sounds. And there's also the formation of visual and conscious memories. It interprets visual stimuli and recognizes objects. It helps you to recognize faces along with the frontal lobe. There is some production of speech that happens in your temporal lobe and the recognition of language. There is some control in our unconscious and automatic reactions, appetite, thirst, and hunger alongside the hypothalamus and the amygdala. And the Broca's area is involved in the production of speech, and the Wernicke area is involved in understanding speech. So a lot of speech going on in the temporal lobe. Parietal lobe, we're moving on to the top, houses the sensory perception and integration, spatial reasoning, the sense of your body's movement in your own space, touch perception as it comes up from the spinothalamic tracts, understanding numbers, processing visual signs, and coordinates hand-eye arm motion, so I can move my hand around like this. There is language processing and management of taste, hearing, sight, touch, and smells, mapping your visual world and working out where things are. And there are strong pathways and tracks to the occipital lobe for your visual perception and spatial navigation. And your sensory cortex is also there. You will notice again that fingers, thumbs, hands, much bigger area in the cortex than you have your shoulders, trunks, hips, and knees. And again, a large portion is put over to your lips, jaw, tongue, and around your mouth, because that's where you get a lot of your sensation from. Your occipital lobe is the smallest of your cerebral lobes. It contains all of the visual cortex, and your Brodmann's area 17 and visual 1 is there, and they are the ones that are deciphering what you see with your eyes. So your occipital lobe also assigns meaning to and helps in remembering visual perception, determines color in our visual field, and assesses distance, depth, and size of things. So those are your cerebral lobes quickly, and we're going on to the diencephalon, which is your thalamus, your hypothalamus, and your limbic lobe. Here it is sitting in the middle with the ventricles around it. In Greek, it means inner chamber, and it's sitting on top of the brainstem between the cerebral cortex and the midbrain, lying just above the hypothalamus, divided into 3. And the medial aspect of the thalamus makes up the upper lateral wall of the third ventricle. So I hope that puts it in context as to where it is. It's involved in sensory perception and regulation of motor function. It relays sensory impulses from the receptors in various parts of this, I can't see that, of the body to the cerebral cortex. It takes the sensory impulse, travels from the body surface to the thalamus. Only sensory information is not relayed by the thalamus's smell, and smell goes directly through the olfactory bulb and into the limbic system, where it is read and interpreted. So the thalamus interprets as well as relays information. It is a huge relayer on of information. The hypothalamus sits just underneath the thalamus, and it synthesizes and secretes all of our neural hormones. It acts as a conduit between the nervous and endocrine systems via the pituitary gland, and it connects the hypothalamus to the limbic system, and has some functions with hunger, thirst, body temperatures, and our circadian rhythms. Hope you're all still with me. The limbic lobe is a very, very complex area. It sits in the middle of the brain and has many different formations within it. It is counted as part of the cerebral cortex and includes the cingulate gyrus, the hippocampal gyrus, the hippocampal formation, the amygdala, the prefrontal cortex, the basal ganglia, and the thalamus can be included in there as well. And our mood, our emotion, our motivation, our learning, and our memory are all derived and sorted out in our limbic lobe, which was first described by Broca. And we still talk about Broca's areas as he found them back in the 1870s. The amygdala is a little small almond-shaped area just in the anterior portion of the mesial temporal lobe. It has many connections to the hippocampus, but it is a one-way street. There are very few that go from the hippocampus to the amygdala. There are three major functions. I'll leave you to read those. And a central element is involved in emotion and fear. And sometimes the amygdala is referred to as the fear center. This is where we learn to be frightened of things, where we remember things that frightened us before, and we are alerted again. And there is the amygdala just popping down there. So it evaluates our emotional significance of events. It reminds us whether we were fearful of something, whether it was dangerous, or whether it caused us to be sad or happy. And it is strategically positioned to help us trigger a fight or flight response. It facilitates in social interactions, helping us read body language and facial expressions to understand whether somebody is cross with us, listening to us, or turned off. I can't see your faces now, so I have no idea. And there's a learning memory in there for fear conditioning and episodic memory. The cingulate gyrus comes in, there are 5 parts of it: the ACC, the MCC, the PCC, the RSC, and the SMA, all there for you. I have to go through quite quickly or we're not going to get through to the end. The cingulate gyrus is very involved in emotion, pain, suffering, empathy, autonomic control, episodic memory recall, spatial imagination, self-awareness, and major parts of depression in the subgenial area. And this is one of the areas that can be targeted with DBS when we are looking at people with long-term depression. The hippocampal formation that comes through the middle is there to help with memory, episodic memory, spatial maps of environment, and it consolidates into longer memory, and this possibly happens during REM sleep. And there is a lateralization in the hippocampal formation, with the left hemisphere looking at verbal autobiography and the right hemisphere at spatial memory. And there you can see it curling round and sitting in the middle. The subthalamic nucleus is a little lens-shaped nucleus, and it's the only area in the basal ganglia that is excitatory. Most of the basal ganglia is there to calm things down and smooth things out. But this is excitatory. It's involved with the dopamine circuits and movement, and therefore targeting deep brain stimulation to the STN in Parkinson's disease is great for adults. And in secondary dystonia in children, it also can be very useful to target the STN. That's just looking at all the ways that the basal ganglia and the thalamus connect to everything. Moving on very swiftly to vasculature. So we have a blood supply in. We have 4 main arteries that come into the brain, 2 internal carotids and 2 vertebrals. And these interconnect in the middle of the brain to form the circle of Willis. This interconnection allows blood flow throughout most of the brain, even if one of the major vessels is damaged or blocked for a period of time. Much more of our blood enters via the carotids, and the carotids then split into the anterior and middle cerebral arteries, and these supply the main cerebral hemispheres. The vertebral arteries join together at the level of the midbrain to form the basilar artery, and the cerebellar arteries come off the basilar artery. That's a very brief in the circulation. And there's obviously many major arteries, all coming off the main 4 going in. And that gives you just an idea pictorially of what is supplied by what. So most of the cerebral area is supplied by the MCA and the ACA. And from a drainage point of view, we have major veins and venous sinuses. The venous drainage is via the superficial and deep veins that flow into the vein of Galen or the great vein. And there is a difference between the veins in the body and those in the brain, in the fact that the brain veins have no valves and no smooth muscles surrounding them to squeeze them. Most veins drain into the dural sinuses, the sagittal, straight and transverse sinus, and the CSF is absorbed through the arachnoid villi into the dural sinuses and returning to the circulation. Our blood-brain barrier. Our blood-brain barrier separates the brain and the CSF from the blood. It regulates the exchange of what goes in and out of the brain from the blood supply. And it's structurally made up of capillaries, astrocyte feet, and pericytes. It selectively determines what can move through from the blood into the CSF. And it maintains homeostasis in CNS protection. It protects the escape of neurotransmitters the other way. So it keeps everything in and keeps everything out. And amazingly, this is a good one. You can remember this. The combined surface area of the blood-brain barrier is thought to be 16 to 18 meters squared, which is pretty big. Your blood-brain barrier can be weakened or breached by things. Stress, drugs, smoking, inflammation, disease processes can all weaken the blood-brain barrier and then allow things to leak through it. And there is increasing evidence there are strong links between the fitness of the gut biome and the strength and fitness of your blood-brain barrier. That is certainly something that there's a lot of research on at the moment. And now we've even got drugs that are specifically designed to boost the blood-brain barrier, such as fingolimod, used in multiple sclerosis to boost the blood-brain barrier in order to protect the brain. CSF. So I love this, this picture, which I believe one of the ISPN guys put together a few years ago. It just shows how the CSF is made, travels round and through, and comes back again. It is in a circle. So it comes from the blood through the choroid plexus into the lateral ventricles, into the other ventricles, through the spinal subarachnoid space, and then reabsorbs through the arachnoid granulations and back into the blood system. CSF is an ultrafiltrate of plasma. It's contained within the ventricles of the brain and the subarachnoid spaces, and it provides nourishment, waste removal, and protection. So there's about 150 mils in an adult system, and we produce between 500 and 600 mils a day, therefore replacing our CSF 3 to 4 times a day. It's one of the areas that there is still a lot of research on. We believe that the majority of CSF is made in the choroid plexus tissue, but there may well be made elsewhere as well. Essentially, there are fenestrated capillaries around other cells, and plasma is filtrated through and into the CSF spaces. That is a very simplified way of talking about it. An electrical potential pulls chloride, sodium bicarbonate from the plasma, creates an osmotic gradient, and then will pull water into the CSF as well. And it travels, CSF travels through the ventricular system via convective and pulsatile means. And whereas it was always thought perhaps to travel just in one direction, with the pulsatile action, you actually see CSF moving both ways, but predominantly down. A fact I learned many years ago was CSF moves about the same pace as the Florida Everglades. There's also one that you'll never forget again. So CSF is clear and colorless, as we know, and it's there for CSF homeostasis. It protects by acting as a shock absorber and allowing the brain and spine to float and be buoyant, reducing the weight and the strain on the tissues. It nourishes by bringing things from the blood through the choroid plexus and into the brain, and it takes away waste removal, brain metabolism, excess neurotransmitters, and the lining of the ventricles, as we all know, that blocks our shunts. It can also take out bacteria and other foreign material. I love this. This is a really nice picture on how CSF comes and goes and around. I haven't got time really to go through it, but if anybody wants it, I'm very happy to send it on. And CSF is recycled through the arachnoid villi, which are present in the arachnoid mater, and they go into the venous sinuses. A pressure gradient between the subarachnoid space and the venous sinus creates the pull for the CSF to be pulled through by osmotic pressure. So we just mentioned very briefly there the meninges. The meninges are the coverings of the brain, and as you know, there are three: the dura mater, the arachnoid mater, and the pia mater, and they have two functions. They're there to provide a framework for the cerebral and cranial vasculature, and they act to protect the CNS from mechanical damage. The dura mater is the outermost layer of the meninges, directly underneath the bone of the skull and the vertebral column. Two layers of connected tissue with the periosteal layer and the meningeal layer. And there is dural venous sinuses between the two layers, and they are, as we have discussed, responsible for the venous drainage, and they empty into the jugular veins. They have it has its own vascular supply from the middle meningeal artery, and is innervated by the trigeminal nerve. So it has its own nerve supply and its own circulation. The arachnoid mater is the middle layer, and it consists of connective tissue. It is avascular and has no innervation, but it does have in it, very importantly, in the subarachnoid space just underneath, all the CSF, and also the arachnoid villi that are going to pull the CSF back into the circulation. The pia mater is underneath the subarachnoid space. It's extremely thin and adheres to the surface of the brain and actually follows the contours of the brain into the gyri and fissures. And it is highly vascularized. It has its own blood vessels which perforate it and into the underlying neural tissue. Moving further back now to the brainstem, we're almost there. Just stay with me a little bit longer. So the brainstem, we're looking at the pons and the medulla. The pons is important in the fact that quite a few of the cranial nerves originate from it. I'm not going to talk about this very much because Kathy is going to talk about it very shortly. It's intimately related to the cerebellum and connected by the cerebral peduncles. It's made up of many tracts passing through it. We have descending corticospinal and corticobulbar tracts, and we have ascending medial lemniscus and spinothalamic tracts also coming up, responsible for motor things and sensory things. just to put it in context, the top of the medulla creates the fourth ventricle floor. And when you have a look at it, there's like two swellings on the anterior side, and they are called the pyramids and olives. Another thing to remember that will never help you again. The medulla connects your brain and spine together and plays a really important role in relaying the messages between the brain and spine, and has some control over the cardiovascular and respiratory system rates, and your vomit center is in there as well, which always makes me laugh. And your motor neurons cross the body within the medulla. So as we all know, the right side of your brain controls the left side of your body, and this is the point at which they cross in the body. Several cranial nerves arise from the medulla, the 6th, 7th, 10th, and 11th. And Kathy will discuss those shortly. So we're almost there. Cerebellum is the second largest structure in the brain. It makes up just 10% of the total volume, but is estimated to have 50% of the brain's neurons. So a lot goes on back here. It lies inferior to the occipital and temporal lobes and is separated by the tentorium, or the tent, part of the dura mater. And it lies at the same level, but posterior to the pons, and it's separated from it by the fourth ventricle. Key functions of the cerebellum include posture and balance, mental function, movement, motor learning. So things like learning to ride a bike, where you keep getting back on and learning, trial and error and fine tuning. And there are visual areas of your cerebellum as well that help with vision. And while the cerebellum is not thought to initiate movement, it certainly helps to organize all of the muscle groups and make sure that there is a fluid, coordinated movement. And this includes eye movements and movements associated with speaking. We get to the end. Happy to take any questions if anybody has questions, or if anybody wants to know anything else. If not, I will hand to Kathy. In fact, Noor first.
Hey, Jenny, can I make one comment?
Yes.
First of all, that was a tour de force. I'm going to make it two very brief comments. One, don't anybody get intimidated just because you don't understand every bit of the anatomy. You can do tremendous good work and not know that all of the details of that anatomy. So don't be intimidated. Number two is you mentioned that the limbic system, it can be very complex. I heard a good adage to think about the limbic system somewhere along the pathway where I was learning all of these, and it was basically think of a small vulnerable animal that's prey for other animals, and everything that the limbic system does is what helps keep that animal alive, right? The fear system, the fright, flight, the strong sense of smell. It can sniff out its little bits of food, think of a squirrel or a rabbit or something like that. And it learns very simple things very quickly via the limbic system. So, I mean, the nervous system works by building increasing complexity on top of simple layers, from the most basic reflex to the brainstem functions to the midbrain and so we're complex, and we have all these cerebral things on top that are wonderful, but that complicate it. So if you want to have a little bit of a cheat sheet for the limbic system, just think what a small animal that's being preyed upon needs, and all those things are right there, and that's the limbic system in a nutshell.
That's a wonderful analogy. Thank you.
Exactly. There are so many things that have been undergone a lot of variation, like the lobes of the brain, because nowadays surgeons do recommend that to recognize the central lobe of the brain, which comprises of the motor area and the sensory area, and they think that from a functional point of view, a central lobe should be recognized as such, and a limbic lobe should be also recognized, which is an arch-shaped area, the cortical area, which is on the medial surface of the cerebral hemisphere, but the frontoparietal and the temporal lobes part. So it's a wonderful thing, and nowadays they have even question the homunculus. They say that there are 3 points of interconnection in the homunculus. So I think that they really wish that homunculus need another look, because it might not be the one that we think it was. So again, thank you very much for the amazing lecture. The debate can go on for hours. I'm really pleased to introduce my second speaker, Ms. Kathy Cartwright. She's the director of the Advanced Practice Professional Development at Children's Mercy, Kansas City, with 20 years of experience as a pediatric clinical nurse specialist in neurosurgery. She has spoken nationally and internationally on pediatric neurosciences and professional development topics. She's the past president of the AANN and the president of the World Federation of Neurosciences Nurses and the co-editor of the book Nursing Care of the Pediatric Neurosurgery Patient. And she's a fellow in the American Academy of Nursing. So, Ms. Katie Cartwright, welcome to the show. It's a pleasure to have you here with us, and you are going to deliver a lecture on cranial nerves.
Thank you. Yes,
Gloria.
I'm excited to begin. Let me get I think you can all see my screen now, I hope.
Yes, correct.
Okay, great. That was a great talk, Jenny. I just wanted to comment and say that I just love how you talk about the frontal lobe not being totally myelinated until they're 24, 26, 25, 26 years old, because in the United States, you can drive a car when you're 18, but you can't rent a car until you're about 25 or 26. And so they realized that there's a little bit more developing to the brain before you're fully able to operate such a motorized vehicle. So Jenny did a great overview of the brain as a whole, and I'm going to do a basic overview of the cranial nerves because I think that they can be confusing. We have 12 cranial nerves. We only have 10 fingers. And so when I'm trying to remember them, it's kind of hard sometimes. And so there's a few little tricks and mnemonics I'm going to talk to you about. And this may be familiar to some of you, but it may be new information. And hopefully it will help you remember some of these things. So I'm going to tell you where I work. I work in Kansas City, Missouri at Children's Mercy, and this is our hospital. Kansas City is located in the state of Missouri, which is in the heart of the Midwest, and Kansas City is right there. And those of you who follow American football, we're having the NFL draft in Kansas City right now, and so it's really hard to get around anywhere. Our hospital is located about a block from where they're having the NFL draft, so it's been challenging but fun. So let's talk about the cranial nerves. Jenny talked about the brainstem having 3 parts, the midbrain, the pons, and the medulla. And actually the cranial nerves 3 through 12 are found in the brainstem. But for convenience, we're going to discuss cranial nerve 1 and 2 as they arise from the cerebrum. We're just going to lump them all together. So the cranial nerves can arise from the midbrain, the pons, and the medulla, or actually between those structures. And if you wonder, how did we get these things numbered like they're numbered? Because sometimes you think that they may be out of order. Well, they're numbered by their location on the brainstem and how they exit from the cranium. And so the midbrain, the trochlear nerve number 4 comes out of the midbrain, but oculomotor number 3 arises from the midbrain and pontine junction. There. The trigeminal nerve number 5 arises from the pons, but abducens, facial, and acoustic 6, 7, and 8 arise between the pons and the medulla. You can see there from the illustration. And we have cranial nerves on each side, but the arrows are just pointing to one because it would really make this picture confusing with all these arrows going every direction. So 9 through 12 cranial nerves arise from the medulla, glossopharyngeal, the vagus, the spinal accessory, and the hypoglossal. So sensory nerves are either sensory or motor, or they can be both. So this is just one more thing that you have to remember when you're thinking about cranial nerves. The sensories are afferent fibers. They travel from the sensory organs to the central nervous system, whereas the motor nerves travel from the central nervous system to the muscle fibers. So how do you remember what everything does and what number everything is? So when you were learning this in school, you probably heard this mnemonic to help you. On old Olympus towering tops, a Finn and German viewed some hops. And this lines up with the name of the cranial nerves nicely. And I tell you, I use that all the time because, again, I only have 10 fingers, so I have to go 2 more on the other hand. But it helps me remember what all these nerves are. And then the other mnemonic that you can remember to determine if they're sensory or function is some say Mary, money, but my brother says big brains matter more. So some nerves are sensory, some are motor, and the B is both. So if you can remember this mnemonic, it's a little helpful to keep things straight for me. And here's another little trick that I think is helpful. And some of you may not really get into this, but it's pretty clever, I think. Barbara Bolick wrote about this, over 15 years ago. But it's a cranial nerve face. And so you take a blank piece of paper, and if you have paper, take it out right now and something to write with, and you too can make a cranial nerve face as we talk about these cranial nerves. And as I go through them, I will show you how this all works. And this just kind of gives you a picture in your mind of what these nerves innervate. So let's start out with the first and second cranial nerves, the olfactory and the optic. And they arise from the cerebrum, remember, not the brainstem. And you can see up here where they arise. The olfactory nerve is located in the nose, and it controls the sense of smell. It's not usually tested unless you suspect a lesion. Although if you're taking care of a child who has a poor appetite and you really can't determine what's wrong, you might check their smell because it's closely linked to taste. You can make a game out of testing these nerves because children aren't normally cooperative in a lot of instances. The teenagers may just not want to do it, and some children may be afraid. And infants, you can't tell them to do something. They don't follow commands, but there's a lot of information you can get just by observing very carefully. So to test for this nerve, you have the child close their eyes and you have them smell something. Close one nostril at a time because you want to check each nostril, and use something like peppermint, peanut butter, or orange, some fragrance that they're probably familiar with. On adults, we use coffee because everybody seems to know what coffee is. But don't use things that are real noxious like alcohol because it can stimulate the intranasal pain endings of the cranial nerve 5. Now, if there's a deficit, they'll have no smell, and that's called anosmia. And if they have an impaired smell, they can't quite smell at all. That's hyposmia. But keep in mind that this may not be neurological. It may be due to a respiratory infection, or sinusitis, or rhinitis, or maybe they just stuck a bean up their nose, because we have kids that do that pretty often. There are also some neurogenic causes. Let me get back here. If you have a child who's had a trauma, such as a whiplash from a motor vehicle collision, it can sever the olfactory projections through the cribriform plate and cause anosmia where they can't smell. The frontal lobe lesions, olfactory or bulb tract lesions can also cause a lack of smell, and it could be indicative of a temporal lobe seizure onset. The wrong thing. Go back. There. So for the second cranial nerve, it's the optic nerve, and it's located in behind the eyes, and it controls the central and peripheral vision. It's a sensory nerve, and you want to test the eye one at a time. So hold an object. If you have an eye chart, you can use an eye chart. Not everybody has an eye chart hanging around. You can ask them to look at something in the room, or just hold your badge out there. And of course, the child has to be able to read if they're going to read your name or tell you what it says. But if not, hold your fingers maybe 6 inches away from their face and ask them to count their fingers. Or they could identify a light, or even for younger children, just hold up a toy and ask them to identify the toy. And if you want to check peripheral vision, check it one at a time. Have the child look at your nose, and then put your finger close to their head and move it into their visual space, and ask them to tell you when they can see your finger, because that way you can check some of their visual fields. If there's a deficit, they may have blindness or decreased vision. Some children would describe their vision like a shade is coming down, and that's amaurosis. They could have hemianopsia, which is a peripheral vision loss in half of their visual field, either on the nasal or the temporal side, in either one or both eyes. Or they could have quadrantanopsia, which is a peripheral vision loss in any 1/4 of the normal visual field in either of their eyes. So get out your paper and your writing instrument. Number 1 is the nose, to remind you of olfactory. We have 2s for eyes, and to remind you of the optic nerve. So we've got cranial 1 and 2 taken care of. So now we're moving down to the midbrain, and this is where we see cranial nerves 3 and 4, the oculomotor and the trochlear. The oculomotor cranial nerve 3, this mediates extraocular movements. So when you say that EOMs are intact, you are saying that cranial nerve 3, 4, and 6 are intact. And many of the cranial nerves work in conjunction with each other, and there's a lot of overlap. And so sometimes it's not just one nerve that does something. So you have to assess several in groups. So the function of this nerve, it controls pupil constriction, eye movement, upward, inward, and medial movement. It elevates the eyelid too. It's located in and behind the eyes. So this is a motor nerve. So to test for this nerve, you dim the lights or make sure you're in a relatively dim room, shine the light into each eye, and the pupil response should be equal and reactive. If you want to test for accommodation, you hold the finger in front of their eyes and slowly bring it closer to the center of the patient's face. The pupils should constrict when the eyes converge, and then have them follow your finger in an H pattern so you can get the different fields of vision. If there's a deficit, they'll have ptosis, which is a drooping eyelid. They might have sluggish or non-reactive pupils, or they may just fail to accommodate. Now, remember, this could be due to pharmacological reasons. They may have had atropine, opioids, or maybe ophthalmology came in when you weren't looking and the patient is unresponsive and they dilated the eyes. And then you come in and check them and you see they're fixed and dilated. So it's helpful that if ophthalmology does dilate the eyes, to tape a sign at the head of the bed saying that the eyes are dilated. If you're really concerned about visual fields, you can send them to pediatric ophthalmology, especially before a tumor resection, to establish a baseline if there is any concern that some of the tracts might be disturbed. So the fourth nerve is the trochlear nerve. It arises from the posterior side of the midbrain, and it has the longest intracranial length of all the cranial nerves. It moves the eyes down and toward the nose. It also innervates the superior oblique muscle. So this is a motor nerve, and you test it by having the child look at your finger and moving your finger down and toward the nose. And they should follow your eyes. With their eyes, they should follow your finger down and toward the nose. If they can't do it, they may complain of double vision. They may complain of nystagmus, which is an involuntary back and forth movement with their eyes. It makes you think maybe they have a brainstem tumor or a mass in their posterior fossa that's pressing on their brainstem, like a medulloblastoma, ependymoma, or even head trauma can cause this. So here is number 4, abducens, down and in toward the nose. And then we put 3 on top. Even though it's for pupils, it also raises your eyelids, and so to prevent ptosis. And so that's why we put it up there, to remind you to check the eyes and to check the pupils. Okay, we're going to move on down to the pons, and that's where we find the trigeminal nerve, cranial nerve 5, and it covers most of the face. This allows the child to clench their teeth, have a chewing motion. It controls pain, temperature, light touch in the face. And there's a motor and sensory component. And the sensory component has 3 facial distributions over the forehead, the cheek, and the jaw. So if you want to test for that, you can touch their forehead, their cheek, or their jaw with, if you take it with a cotton swab. You can test for soft with the cotton, but you can test for sharp if you break the wooden stick in two and touch them gently with that. I don't recommend using a needle or a safety pin, because if you go at them with a sharp object, it's going to be really scary. I would only check the corneas if you had a patient who maybe was not alert, because that's very annoying. If there's a deficit, you'll see weakness in their masseter or temporal muscles. And the way to test that is to put your fingers on their temple and ask them to clench their jaw. You want to assess for asymmetry. And then you can also put your fingers on their jaw and have them clench their teeth together and move their jaw back and forth. Ask them to open their mouth. Any pain or discomfort when you touch their forehead or cheek or jaw could be a deficit. Or if there's any unequal or lack of sensation in their forehead or cheek or jaw. So number 5, that's almost the whole face. And so we draw number 5 over the whole face, if you're keeping track. So the next nerve on the pons is abducens, and it controls lateral eye movement. Now, it's a motor nerve. And so to test this with the child's head in midline, ask them to follow your finger in an H motion so that you can get all quadrants. If there's a deficit, the eyes do not move laterally. And they may have nystagmus, they may have double vision or diplopia. Some of these kids compensate with a squint or a head tilt even. Conjugate eyes will move together, and disconjugate, they do not move together. This is a right sixth nerve palsy because you ask them to look to the left and you ask them to look to the right, but the right eye won't look out. So you draw your 6 on here because the eyes control, the abducens controls lateral eye movement. So make it lateral to the eyes. The 7th nerve, the facial nerve, is also on the pons, and it has motor and sensory functions. It supplies the motor muscles that control facial expression, the muscles of the upper and lower face. The sensory component supplies taste to the anterior 2/3 of the tongue, and so it's sweet and salty or sour and bitter. It also has some supply to the salivary, nasal, and lacrimal secretions. And so to test this, you ask the child to raise their eyebrows or frown, close both eyes, smile. They love this one because they love making faces. Ask them to show their teeth or puff their cheeks. And I remember in seeing adults, many of the adults didn't have teeth. And so it was pretty funny when you ask them to show their teeth and they didn't. But even infants with no teeth, when they cry, you can assess for symmetrical movements in their face. Check their nasolabial folds for symmetry too, even if they're at rest. You might notice an asymmetry. If you need to test for taste, you can put some salt or sugar on the anterior 2/3 of the tongue. Just have them stick their tongue out and they can indicate. You could have them hold up a card that said salt or sweet if you want. I have never had to do that. And it would probably be hard to get them to cooperate. So if there's a deficit, you would assess for unilateral or bilateral weakness of the upper or lower face. For instance, they may not be able to keep their eyes closed against resistance. So ask them to close their eyes tightly and then push up to see if you can open them. They may have weakness of the lower face and makes you suspect maybe Bell's palsy. I did have a patient at one time who did have a facial weakness, but turned out he had an arachnoid cyst pressing on his 5th nerve. 7th nerve, I'm sorry, 7th nerve. So this is where we would draw number 7, right here for the whole face, and then you make a backward 7 for the other side of the face. Number 8, acoustic. It's also called the auditory or the vestibulocochlear nerve. It's located in the ear and it's responsible for hearing and balance. The cochlear division innervates the inner ear and provides auditory function, and damage to this component can affect your hearing, whereas the vestibular division is responsible for balance. So this is a sensory nerve, and if you want to test for hearing, there's a few things that you can do. You can whisper in their ear very quietly on one side, whisper a name or a number, and then ask them to tell you what it is. Or you could rub 2 strands of hair right in front of the ear, and it's very soft, and ask them if they hear that. Back when we had watches that ticked, we would put a ticking watch by their ear. You can also say a number and have them repeat that number to you. If you have a tuning fork, you could do the Weber test, where you take the stem of the vibrating tuning fork and put it on the patient's skull in the midline, and you should hear equally on both sides. The patient should be able to hear equally on both sides. And then there's the Rene test, where you take the stem of the vibrating tuning fork and place it on the patient's mastoid process. And when the sound stops, you place it by the ear. And it's abnormal if the bone conduction sound lasts longer than the air, because they should hear it longer in the air. To test balance, you can look at their gait, and you can test the Romberg by having them stand with their eyes closed and their feet together. If it's a positive, if the child starts to sway and maybe falls over. So they may have an unsteady gait, or they may sway. Sometimes they'll say the room is spinning, and you may see nystagmus. But remember, this may be drug-induced. They could have ingested a large amount of alcohol. They could have an inflammatory lesion or a tumor, or cerebellar or a pontine mass. So keep those things in mind when you're doing your assessments. So draw 8s where the ears would be because it's the acoustic nerve. So now we're going to move on down to the medulla, number 9, glossopharyngeal. The function for this nerve is to allow you to swallow. You have a gag. It has a motor and sensory component, and the motor component moves the posterior pharynx. And the sensory component supplies taste to the posterior 1/3 of the tongue and sensation to the inner ear. So to test this, you have them say, ah, and so you look in their mouth and you observe the soft palate, the pharynx, and the uvula. You want to make sure the uvula is midline and the palate raises. If you want to check for a gag, you can touch the back of the throat with a cotton swab, but be careful because sometimes the children will throw up on you. And so I wouldn't test this unless I really had a concern, like perhaps a Chiari patient who was having trouble with their secretions. You can also assess taste at the back of the tongue. A deficit would be indicated with hoarseness, which is associated with vocal cord paralysis. A nasal voice is associated with palate paralysis. And so the uvula or the palate deviates from the affected side. The gag reflex may be absent or even decreased. So you're thinking maybe there's a lower brainstem lesion. But with these patients, you have to be really careful because there is a risk of aspiration. So when you test this, you may need to get a formal swallow study if they're having difficulty with their secretions. And this nerve is also tested with 10. But if you're drawing your picture, you draw 9 back here on the back of the tongue. See, there's like 3 nerves that innervate that tongue. So the 10th nerve is the vagus nerve, and 9 and 10 are usually assessed together because they innervate the tongue and the throat. This nerve has a motor and a sensory component and even a parasympathetic function. The sensory component provides sensation to the outer part of the ear, the throat, the heart, and the abdominal organs. It even provides some taste sensation. The motor component provides movement to the throat and soft palate. It's responsible for phonation as well as the gag reflex. Of course, the parasympathetic regulates heart rhythm and innervates the smooth muscles in the airway and the lungs and the GI tract. So you can test the gag, again, the same as you did for glossopharyngeal by touching the back of the throat and noting any kind of hoarseness or stridor, making sure that the structures are in midline, the uvula, and then listen to the heart rate and the vowel sounds. If there's a deficit, there might be some pathology in the lower brainstem, such as a stroke or a tumor. And again, watch for risk of aspiration when you assess 9 and 10 together, because there may be a problem where you would need to have a swallow evaluation first, or even intubate the patient if it's that bad. So here's number 10 on the tongue again. So number 11 on the medulla is spinal accessory. And this controls neck and shoulder movements, your shoulder shrug and the lateral head rotation. This is a motor movement, a motor nerve. Oops, yikes. So you want to observe for shoulder symmetry, any wasting of the sternocleidomastoid or the trapezius muscle. So to test the trapezius, you ask the child to shrug their shoulders and put your hands on their shoulders so they can shrug against resistance, so you can test strength in one shoulder or the other. And then test the sternocleidomastoid by having them turn their head to the laterally to one side. And they can do this against your hand so that they have to use some force, and you can assess their strength and their equality of strength on both sides. Deficits would be weakness or asymmetry. They might have a shoulder drop, and it makes you think maybe there's a tumor or maybe even a cervical injury that needs to be looked at. So I'm going to continue down to get on my last nerve here. But you see 11 are the shoulder nerves. So you would draw them on the shoulders because that's shoulder shrug. So the last nerve is the hypoglossal. And this also controls tongue movement, and it's a motor nerve. So this is the kid's favorite. They like to stick out their tongue because they're usually not allowed to at home. It should be midline. It should move side to side. And when you speak to them, look for any difficulty in their speaking, or if you're watching them eat, make sure that there's no trouble swallowing or eating their food. And again, check with cranial nerve 9 and 10 when you're assessing their swallow. Any kind of atrophy or abnormal movements or slurred speech, dysarthria, would be a deficit. And this could involve, cranial nerves 5, 7, 10, and 12. So if the lesion's in the brainstem, the tongue will deviate to the side of that lesion. And I have seen kids stick their tongue out where there were actual fasciculations on one side of the tongue. And I've also seen weakness where they stick out one side of the tongue and they can't stick it out straight. It goes to one side. So it's important to check the tongue. There's a lot of information that you can get there. So put 12 on the tip of the tongue. And so your picture is complete if you've been following along and drawing the picture. And for my last follow-up, my last slide, I just wanted to follow up with a few questions to see if how much you remember. So if we were in an audience where you could raise your hand, I would call on you, but we'll just kind of review here real quickly. So the cranial nerves that you use to smell and see would be 1 and 2. To look around, these are your extraocular movements, 3, 4, and 6. Pupils, you know what pupils are. That's like the easy one, right? 3, oculomotor. Have them clench your teeth. That's 5. Ask them to smile and test their hearing. That's 7 and 8. Have them say ah and check for the palate rising, the uvula. Check their swallow, which is 10, and have them shrug and stick out their tongue. And if you've done all this, you've checked all the cranial nerves. So it's fairly straightforward. And if you have your pictures and your mnemonics to help you out, hopefully this will give you some hints and make cranial nerves not so mysterious, because as I said, there are more cranial nerves than you have fingers. There are references if you need to look this up. There's some great mnemonics and videos.
Excellent, Katie. Even for us, this mnemonic way to keep in mind and to teach students is fantastic. Thank you very much. It's a broad overview on these cranial nerves and help even us to keep in mind.
Yeah.
Thank you very much. Well done. And for the audience, just compliments for the lectures. It's very important for us to have this feedback. And the audience, feel free if you have some questions, we'll try to answer after each lectures or at the end. Please put your questions on the question and answer chat box, please. Some words, Jeffrey, or you can move to Nor Maria to introduce the next speaker.
Not much other than to add exactly what you said. I found that diagram very helpful with regard to helping learners and keeping people from getting intimidated, because the sad reality is that people tend to walk away from neuro or put it all in a black box unless little practical things like that can help people navigate and get some confidence. So I agree with Nelsie. Very well done and very, very practical approach. As practical of an approach to the cranial nerves as I've ever heard. So bravo, well done, and on we go.
Thank you very, very much. It was a wonderful lecture. I hope that many people, especially the junior residents and the trainees, must have enjoyed it and do think that it is very important to remember all these things, and they will find it very insightful. So thank you. So I'm pleased to introduce the last speaker of today's session, Ms. Ashley Birch. Ms. Ashley Birch has earned both her BSN and MSN at Regis College and has been a nurse practitioner at Boston Children's Hospital since 2015. She has worked in both inpatient and outpatient neurosurgery. Prior to that, she worked in strokes research at Massachusetts General Hospital and in Rhode Island in pediatric sedation. As a nurse practitioner at BCH, Ashley has focused her practice on caring for patients with hydrocephalus and spina bifida, and she has been privileged to work in the multidisciplinary spina bifida clinic She was awarded a Global Nursing Fellowship in 2019 and has been have very vocal at various local and international conferences with for the spina bifida as well as hydrocephalus, especially in the low middle income countries. She has also served on the board for Spina Bifida Association of Greater New England and has as well as a non-profit NeuroKids Association. So Ms. Ashley, I think she's here with us.
She's traveling. Probably we have a recorded lecture.
Oh, okay,
But
great.
Thanks for being with us, Ashley, even if you are not able to share. Thanks for seeing your lecture now.
Seems to be progressing, but I don't think we have sound.
And Linda, it was with voice.
Linda,
One
just try-
second, I'm restarting.
Yes, exactly. Just change the voice input.
Excellent. Should work usually.
Hi, my name is Ashley Birch.
Yes.
I'm a pediatric nurse practitioner and I work in Boston, Massachusetts at Boston Children's Hospital in the United States, and I work in pediatric neurosurgery. Today I'm going to be talking to you about the neuroexam of the spine. We only have 20 minutes, so we're just going to be talking about the most important things that you need to know. I'm hopeful that the diagrams, links, and videos within the presentation will be things that you'll be able to use long after the presentation to help you out with your exams on your patients. Patients who might have a compromised neuroexam of the spine include patients with a spinal cord injury, patients with spina bifida, patients with a disc herniation, patients with degenerative disease, and patients with spinal tumors. I'm just going to briefly talk about anatomy because we don't have enough time to talk about it all here. But the spinal cord is within the spinal column. There are 33 vertebrae in the spinal column. 5 form the sacrum and 4 form the coccyx. There are discs between each vertebral body except C1 and C2. The spine is divided into 4 sections. That's not including the tailbone. So C-spine is C1 through C7, and that's the neck. T-spine is T1 through T12, and that's the upper back attached to the rib cage. The L-spine, which is the lower back, it's L1 through L5, and the sacral vertebrae, which is S1 through S5, and that's your pelvis. There are 31 pairs of spinal nerves and roots. 8 nerve pairs exit the cervical cord at each level, and they go on the left and on the right, and the same thing with thoracic nerve pairs, but there are 12 of those, and then 5 sacral nerve pairs. The peripheral nervous system allows for the conduction of nerve impulses to travel to and from the brain from the spinal cord to a specific location in the body. There are tracts within the spinal cord, which are neural pathways in the cord. They carry information up and down the spinal cord, and they connect the brain to the rest of the body. There are afferent pathways, which receive and conduct sensory information, and there are efferent pathways, which regulate motor function and autonomic visceral fibers. When you're doing an exam on the patient and you're focused on the nerves of the spine, you're looking for several things. You're looking for the dermatome, which is the area of skin innervated by the sensory axons of each nerve root that corresponds to a spinal cord segment. You're looking for a myotome, that's the muscle groups innervated by the motor axons of each nerve root that corresponds to a spinal cord segment. You're looking for the sensory level, which is the lowest spinal cord segment that has normal sensory function on both sides of the body. You're looking for the motor level, which is the lowest cord segment for which the associated muscle group has a strength of at least 3, as long as the key muscles of levels higher also remain normal. And you're looking for the skeletal or the vertebral level, which is the level of the lesion or the level of the injury. I just wanted to have a brief slide on dermatomes because we see them everywhere, and I'm not sure that everybody exactly knows what it is. But here's the dermatome picture that everybody's seen and everybody knows. The dermatome, again, is an area of skin in which the sensory nerves derive from a single spinal nerve root. And it helps to assess radiculopathy or neurologic defects, as radicular patterns can suggest specific spinal nerve involvement. So this just goes through all of them and kind of gives you cheats of where each level is. So for instance, if someone has sensory issues at C6, then that's their thumb. Their thumb is C6. Your nipple level is T4, and your umbilicus, your belly button, is T10. So if they're able to feel till T10, then you can identify where a lesion is from there. Some important terms to remember are the way that you describe what you're seeing in your exam. So flexion is when they bend, extension is straightening, adduction is bringing toward, abduction is taking away. If you're talking about proximally, then that's closer to the center of the body, and distally is toward the outside of the body. Let's talk about some tips and tricks. So prepare all of your tools ahead of time. Make sure that you have your reflex hammer, make sure you have any toys that might help a child finish an exam, and also have all of your tools that help with your sensory exam. You do the same exam every time, especially when you're new, when you're first starting out. Compare the left side to the right side on whatever you're doing. Move from the upper to the lower extremities and move from the inside to the outside, proximal to distally. Test everything against gravity. See if they can move against gravity. If there's no movement, look for an attempted contraction. If there's no voluntary movement, evaluate a response to pain. Look for atrophy, look for bulk, look for wasting. And for spina bifida, don't forget that the anatomic level of the lesion and the functional level are not always the same. The next thing that's important in documentation and in knowing how strong your patient is muscle strength grading. So a 0 out of 5 would be no muscle contraction detectable. 1 out of 5, very weak muscle contraction is palpated, and only a trace of contraction is evident, but no active movement of the body part is noted. It's trace movement. 2 out of 5 would be active movement of the body part when gravity is eliminated. So that would be poor movement. 3 out of 5 is active movement of the body part against gravity. So it's fair movement. 4 out of 5 would be active movement against gravity and some resistance. The examiner can overcome the muscle resistance, so it's good movement. 5 out of 5 would be active movement against gravity and full resistance, normal strength testing, so that's normal. And you can also add pluses or minuses to each one if you feel like it doesn't really fit into the category. This is a diagram of the important muscle groups that we'll be talking about today. Some of this is self-explanatory, but when you're doing sensory testing, you should do superficial sensation, light touch, pain, deep sensation, and proprioception. When you're doing the sensory exam, I think one thing that's tricky and that not everybody knows what it is proprioception. So that's your position sense, where you are in space. And so this video that I've included here will show you how to examine that.
Next test is we're going to test his position sense, and I'm going to show what I'm going to do. I'm going to move your finger just a little bit down, or a little bit up, or up, up, down, down. I want you to close your eyes and tell me I'm moving your finger. Okay? Now.
Up.
Good.
Up.
Good.
Down.
Good.
Down.
Good.
Down. Up.
Good. Now I'm going to do the testing over here. And I'm going to move a little bit up, a little bit down. Close your eyes.
Down. Up. Up. Down. Down.
Very good. Do the same thing here on your lower extremities. And just rest your leg right there. And I'm going to now move your toe. I'm going to move it down or up. Close your eyes. Tell me which way I'm moving. A little bit down, a little bit up. Okay, ready? Now.
Down.
Good.
Down. Up. Up. Down. Down. Up.
Good. Do the same thing over this foot. Close your eyes. Okay, I'm going to move it.
Down.
Good.
Up. Up.
This is a busy slide, but it's really important in talking about upper extremity neuromuscular evaluation. So it tells you the nerve root that you're looking at, the reflex that's associated with it, the muscle group, what sensation you're looking at, and also what the exam is that you should be doing. So for C4, you would have them shrug against resistance. C5 is your biceps reflex, and you're looking at the deltoid and the bicep muscle. So you do shoulder abduction, so you do chicken wings and you push against them, and elbow flexion, so you hold the elbow and you have them pulled toward their face. C6 would be looking at wrist extensors and your bicep muscles. So again, you do elbow flexion, but you also add elbow extension. So they flex their arm and the examiner pulls, and wrist extension. So they flex the wrist against the examiner. C7 would be your wrist flexors, your finger extensors, and your triceps. So you do elbow extension, which we already talked about, wrist extension, which we already talked about, finger extension, which you open the hand, palm down, and the patient pushes up against the hand, and finger flexion, which opens the palm upward, fingers curled, examiner grasps fingers and pulls down while the patient pulls up. C8, which is your medial forearm for sensation, and your finger flexors and hand intrinsics. So it's wrist extension, which we already talked about, finger flexion, which we already talked about, and finger abduction. Fingers spread against the examiner, and the examiner provides resistance. T1 would have to do with your interglossal muscles, and that's finger abduction again, which we already talked about. And this is just a short video from an excellent website that shows you the exam of upper extremity strength.
Strength now, and what we're going to do is start proximal. Strength now, and what we're going to do is start proximal and go to distal. We're going to have you hold your arms up like this. Don't let me push down, testing the deltoids, which would be C5. I want you to hold your arms up like this, testing the biceps, which would be C6. And now I want you to put your arm out straight. Don't let me pull it back, and that'll be the triceps, C7. This one again, we're going to try. Very good. And now hold your wrist up. Don't let me push them down. Keep up there. That's C8 and down like this. Don't let me pull them up. Very good. And then hand grip would be T1. Squeeze tight, very tight. Good. Don't let me go. And now let go. I want you to put your hands out like this. Surround wide, testing the dorsal interossei. Very good. You can also look at apposition of the thumb and the little finger. Put your finger there. Don't let me pull through.
I thought it would be important to include level of function in this because it's something that we don't always talk about all the time. You're doing an exam, but you're not necessarily thinking about if the injury is a certain place, what you should expect ahead of time. So you have an injury to C1 to C3. It usually results in limited movement of the head and neck only with paralysis below that region. They'll have difficulty talking and require the use of a ventilator to breathe. If you have a C5 level injury, you'll have partial upper extremity function. C6 would be, you'd be able to maybe stand with an orthotic, but it's very little movement. For a thoracic spine injury assessment, T1 through T5 nerves innervate the muscles of the upper chest, mid-back, and abdominal muscles. And this includes your rib cage, your lungs, your diaphragm, and the muscles that help you breathe. T6 through T12 nerves affect abdominal and back muscles, which are involved in balance, posture, and coughing. So usually you have paraplegia and you have little or no voluntary control of bowel or bladder. Functionally, T2 level of function would mean that you have a complete upper extremity function. T3 to T8, you can stand with a stander. T4, you might have some exercise ambulation. T9 to T12, some exercise ambulation. T10 to L2, you have bladder function is impacted. T11, you have some function of your trunk muscles. And T12 to S5, it depends on if you have sexual function. Again, another busy slide, but I think this diagram is really important because it shows you the nerve, the reflex, the muscles, sensation and testing all in one. And so what we'll focus on is the nerve, what muscles that innervates, and what tests you have to do to see if you actually have that and what kind of strength you have. So for L1, you would do hip flexion. The patient raises the knee to the chest at 90 degrees against resistance from examiner. From L2, you would also do hip flexion, but you would add adduction. So the ability to move your legs inward toward each other against resistance from the examiner. L3 would be your quadriceps, knee extension, which the patient bends the knee to 90 degrees while the examiner puts the hand on the knee and ankle and asks patients to straighten the knee. L4 is your anterior tib, so it would be knee extension that we just talked about, and dorsiflexion. Dorsiflexion is the ability to lift up your toes toward your head. So patient pulls the ankle back and brings toes toward the head while the examiner tries to push the toes down. L5 involves the muscles that have to do with inversion, so moving your ankles inward, hip extension, hip abduction, so moving the legs at the knees away from the body using the hips against resistance, knee flexion, so the patient bends the knee and brings the knee toward the bottom. When knee is at 90 degrees, the examiner tries to straighten the leg while holding the knee. And dorsiflexion, which we already talked about. S2, 3, and 4 have to do with the external bladder sphincter and external anal sphincter. And so that has to do with bladder control and anal contraction. And one way you can test this is with urodynamic studies. So for functional level, if you're in L1, you have complete trunk function, you have some exercise ambulation and sometimes household ambulation. L2, you have hip flexors, so you have exercise ambulation and household ambulation. L3, you have knee extensors or quads, you have household ambulation and possible community ambulation. L4, you have medial knee flexors and ankle dorsiflexors. L4, S5, you can walk in the community. L5, you can walk with or without crutches in the home. With the sacral level, you also have hip adductors, but with some weakness, it would be 3 out of 5. For S2, you have hip extensors, 4 out of 5. You usually have some plantar flexion, and you can walk with or without crutches. S2 to S4, bowel and bladder function varies. You may or may not require help with voiding. And S3, you may have all muscle activity within normal limits. And to put this all together, here's another video that shows the exam of lower extremity strength.
Now we're going to muscle strength. We're going to start at the proximal extremity and move to the distal, and start with having you lift your leg up and don't want to push it down. We're testing the iliopsoas, which would be L2. Now just relax. We're going to have you squeeze in with your knees. I'm going to push out and testing the adductors, and then the abductors push out. Good. Now have extend the leg all the way up, looking at the quads. That would be L3. And now have you bend the leg back here. Hold it there. Don't let me pull it out. Testing the hamstrings, which would be about L5. And now have you bring your foot all the way up, testing the anterior tibial, which would be L5. Now put your foot all the way down, would be S1. And now we're going to position your foot down and in, and push out would be the posterior tibs, and now down and out the perineal muscles. Good. We're going to do the same thing over here. We're going to ask you to push your leg up like this. Don't want to push it down. Good. Let it relax. Knee out. Good. Hold it there. Don't let me pull it out. Good. Bring your foot all the way up, and your big toe up. Don't let me push it down. Very good. Now push down on my hand. Good. And let me position your foot in. Don't let me push it out. Relax. I'm going to push it out. Don't push it in. Very good.
Some descriptors of abnormalities or definition of abnormalities that you should think about are hemiparesis or plegia, which is weakness to paralysis of half the body. It's the same side, arm and leg. Paraparesis or plegia, which is weakness to paralysis involving 2 of the same extremities. So that would be like both your arms or both your legs. And quadriparesis or plegia, which involves all 4 extremities. Gait has to do with both brain and spine, but just to describe some different gaits that you might see out there. A hemiparetic gait would be when you have a leg that swings outward and forward and the toe drops or drags. This can be seen after a stroke. The scissor gait, which is short steps with thighs crossing over one another at the knees. It's associated with a spinal lesion. It's also associated with cerebral palsy. A steppage gait with high steps with foot dropping or slapping on the floor, and this can be associated with peripheral nerve damage. A taxic gait, which is a wide-based gait with unsure staggering steps. This is usually a cerebellar disease. At Trendelenburg gait, which is hip abductor weakness and a droop to the contralateral side when walking, so you get a waddling gait. So you get paralysis or paresis of the hip abductors, and that's what causes it, and this can be seen in spina bifida. I'm not going to play this video, but the link is here so you can watch different videos of different gaits. This is just to go over reflex testing again. So if you're testing the bicep, the reflex at the bicep, then the nerve root involved would be C5 and C6, and you'd be testing the muscle of the bicep. Brachioradialis would be C6, and that's the same muscle. Triceps, C7. Patellar would be L4, L2, L3, and that's your quadriceps. Ankle would be S1, and that's your gastroc. And so the way that you grade reflexes are, if it's 0, it's no response for 0. Minimal response would be 1. Mid-range to normal would be 2. Slight hyperreflexia would be 3. And exaggerated with clonus would be 4. And you can put a plus or minus. When you're evaluating reflexes on a patient, some that are abnormal can be concerning. If the Babinski, where the toes turn up and fan out, occurs in someone that's older than 2 years old, that can be worrisome. An absent anal wink, where the muscles tighten around the sphincter, if that doesn't happen, that can be concerning. Hoffman's reflex, when you flick the ring or middle finger as the examiner, if the thumb twitches on one side, you would worry about that. Decreased asymmetric or increased responses to reflexes can be something to pay attention to. Some reflexes are subjective, so you have to take that into account, but you'd have to think about that closely. And then clonus. Clonus can be one thing that's tricky if you've never seen it. Clonus is an involuntary and rhythmic reflex that is related to the upper motor neuron lesion, and it's a form of hyperreflexia. So it's a bouncing, and usually you see it in the feet. And this is a video that shows you what it looks like. Examining a patient that's unconscious can be tricky, especially when you're suspecting a spinal cord injury. The thing that's most important is really determining what movement is purposeful and what is not. You really have to use pain and sensation as your friend. You have to elicit pain in certain areas to see if they can feel you, if they're not on if they're not paralyzed. Looking at tone, looking at if they're really tight or really loose. Looking at movement patterns to see how they're responding to your exam, doing reflexes to see if they're hyperreflexic and if they've had what kind of injury that they've had, and if they're having decorticate or decerebrate postures, these carry a poor prognosis. And in the next slide, I'll show you pictures of what these look like. So, as you can see, in the first one, your head and neck are arched, the legs are straight, and the toes are pointed downward. In the decorticate posturing, you have closed hands. Things are pulled in toward your body. Closed hands, the legs are internally rotated, and the feet are turned inward. Arms are adducted and flexed against the chest, where in the other one, they're straight and extended out. I remember when I first started out, I was really stressed out about how to document these things, and I was shadowing a neurologist at the time, and she told me something really important. She said, you really just have to describe what you see. You don't need the right words. The next person should just be able to know what you were talking about. And I have remembered that forever, and if I sometimes don't know the right term, I just write what I'm seeing, and I think it can be really helpful to the next person who's trying to do an exam on my patient. So just write what you see. And bulk and tone are also really important. Making sure you're looking at if someone has increased tone or decreased tone, if they're spastic, and bulk, if they have a low bulk and tone, that's really important. Sensation is really hard to determine in young children, so use your tools and see if you can tell where their sensation stops and starts. These are my references, and I just want to credit that the videos are from this website that's listed here, and they are available to be used for learning and education, so please feel free to click on this link and look at these at any time. Thank you for listening. I hope this was helpful. If you have any questions, there's my email there.
Thank you very much, Ashley. You are if you are not driving and you can say to us, hello, we are open your mic. Thank you very much. It was a great lecture.
Hi, everyone. Thank you for listening. I hope that was helpful for everyone.
Excellent, Ashley. Really good. And I would just add that with imaging having evolved the way that it does, it's happening all too often that people are skipping over the exam, right? They get a complaint and then they quickly jump to the imaging. Well, I would counsel against that, because you have to put the context of what you see on the imaging with the exam to do it correctly. Sometimes imaging studies show something that's not really what's causing the trouble. So while it's very tempting with good imaging and available imaging to say, you know, here's a 7-year-old boy who has a headache, here's his MRI scan, that's opening yourself up to not really knowing what's going on with the kid and not really being able to interpret the scan. So the emphasis of these little sections here on a very practical neurologic exam is really to be applauded. And I will tell you that I learned and was reminded of important parts of my exam and the exam that I see my team do with these little video clips and these little summaries. So thanks to both of you or to all of you, excuse me, for incorporating that.
Well, thanks. I really want to add another point over here, echoing your thoughts. I can tell you, I had a patient a few months ago, and she's presented to a specialist neurosurgeon with a foot drop, and the specialist neurosurgeon had her MRI scan, where obviously she was 48 years old. She had a slip disc, and he said, and it was on a higher, it was not exactly the one which was impinging her nerve root. So he said that just get an immediate, surgery. But she was obviously reluctant, so she presented elsewhere, where it was quite obvious that it wasn't her nerve root injury. It was the peripheral nerve that obviously she was traveling a long distance from another country, and she had her luggage below her knee. The mechanism of injury was obvious. The examination findings were obvious that it was a common peroneal nerve that was causing her foot drop, and she was about to get a whole surgery for her disc, which wasn't symptomatic at all, and she eventually made recovery in about a few months, and she's doing great now, and there's nothing wrong with her disc and nothing like that. So it was just because doctors are relying more on imaging and less on examination, which is a very serious thing in cases like the one I have mentioned.
That was a great talk, Ashley. And I just wanted to add that when you're talking to children and trying to assess them, some of these terms, even the grown-ups don't understand. So they can actually tell you a lot of good information if you ask them in the right way. I had a 4-year-old with a cervical spine injury who told me that the feeling in his hands was like a clown was slapping my hands. And I think it was probably numbness and tingling, but he doesn't know numbness and tingling. And I don't know why he said a clown, but somebody was slapping his hands, but that's how he described that feeling. So I think it's important to maybe use their language or let them speak to you in their language.
Very important topic. On these days, we try to do several things at the same time, and we skip the routine time to time and touch the patient, talk with the family. I think it's very important to do the right medicine, the right pediatric neurosurgery, and not just jump on the MRI like Jeff says. Even for us, we need to every single day to be back and do better. If not, we just jump an image and we can be wrong decision. But it's very important, yes. Dear Jenny, the next will be recording videos, is right?
I think so. I hope Linda's there. Linda, if you could play one of the ones that came first.
Sure.
What I'm hoping is that everybody who is watching today, we'll watch the first video, and just see what I'd love it if people would just like to put some comments as to whether they agree with what's being said, whether they don't agree with what's being said, if they have any strong feelings about what's being said. Let's see if we can get a discussion going. Please, you can write things down in the is it in the question and answers, Linda, that people can write, or the chat?
No, the Q&A.
Q&A. So if you have some something you'd like to say, please pop it in the Q&A, and then myself and Kathy and Nelsie, Nora and Jeffrey and Ashley will come back to you, and we'll see if we can get a conversation and discussion going. Okay, Linda, please play the first one. Thank you so much.
So Sharon, we know that neurosurgery is a very tricky specialty. It's constantly changing and there's a lot to know. So what would you think is the most important skill for you to see in your nurses?
I think we're going to be talking about not actual physical skill, but the ability to prioritize what is important, prioritize what is important in the unit and the patients. So it comes into your knowledge, your organization, and then the respect. And I think that is probably the one most important thing for me to know, that my nurses know what's the most important thing that is needed for this child,
for the patient,
or the set of child within the team.
So in terms, you obviously do operations in theatre. So for your theatre nurses, what would you see as their most important skill to have?
Again, it's still the prioritization, but also the ability to communicate, to say that's not right, or I'm trying to get it, just to calm everything down. They do need to communicate clearly. And I think in the theatre nurse, that is number one. I can remember a couple of situations where I was in a TIS, things weren't going right, and we needed more equipment, and the nurses were scrambling around trying to get it. But it took the most senior nurse to say, everyone, we're getting it, we're going to do this, and actually communicate it clearly, and then everyone worked perfectly as a team again. And it is that ability to communicate and work as a team in theatre.
Well, I will say, having worked with you in theatre, your communication skills are excellent in theatre, and your ability to calm the team and to prioritise what's important at the time is actually a phenomenal skill that you have.
Thank you.
Okay, so this was a neurosurgeon and one of the specialist nurses from Perth in Australia. We have various little clips from South America, America, Europe, Qatar, and Australia. So thinking, I'm throwing this out to the audience. I hope they're still listening out there. So the doctor there was talking about prioritization and the knowledge of what is most important for each patient, and then to be able to communicate. And what do other people think about this? Do you think that's one of the most important skills that a neurosurgical nurse requires? Can anybody type to me, or maybe the rest of the panel would like to come in there whilst somebody types something to me?
Yes, it's very important, prioritize, and the ability to communicate, to avoiding errors. But I would like to stress there is a main quality that I'm looking for usually, the ability to have care about others. It means I care about what I'm doing. I care about the feeling for the others. It's not only a mechanical reproducer, because you can be an excellent technician, but you can be able to talk with children, to receive family, and to lead a team. You need to care not only about patients, but you need to care about your all group working with you, other nurses, respectful, and other professionals. the nurse is a leading, in the absence of the doctor, she is the responsible. She needs to feel, to be well prepared, but besides to communicate, she needs to be humble and to accept that maybe we need to move around and do differently than the protocol just to save lives. I think it's a quality very important to try to find out before to choose your partners.
So, and Chantel, thank you for joining us today. I don't know where you're joining us from. Chantel says that communication is very important, along with empathy. And I think this is very true in trying to connect with both your patient and your surgeon. The ability to have some empathy for both the spaces that these people are in is very important. And I think that for me, nurses are the bridge between the medical teams and the patients and their families. They spend a lot of time with the patients, whereas the doctors often come in, leave words of wisdom and go out again. So I think communication is hugely important. I agree with you totally, Chantel. And the ability to link the communication between the families, the patients, and the medics is very important. I don't know if anybody else has anything that they would like to say about that little snippet, or whether we play another one. I don't think anybody else is writing at the moment. Perhaps, Linda, we could play another one. Thank you.
So hi, I'm Zoe Maudsley, Ward Manager at Alder Hay of the Neurosurgical and Trauma Unit. I'm here with one of our consultants to discuss what we think makes a good neurosurgical nurse.
Thanks, I'm Vijay Vakaria. As Zoe says, I'm a neurosurgical consultant here at Alder Hay, specialising in paediatric neurosurgery.
So our first question, Vijay, is what we think makes a good neurosurgical nurse.
So I think from my perspective, good neurosurgical nurses are very good at communicating, very good at keeping the medical team up to date with how patients are progressing. And I think more and more within the NHS, that sort of burden of care is increasing for nurses and their scope, both of practice and the skills that they have are certainly increasing. And what I like to see is people who are confident, people who are conscientious, and people who know how to escalate their concerns appropriately to the medical team. And I think that sort of interaction improves the working relationship. Also, you know, I put a lot of weight into the nursing team being aware of how patients are progressing, how they're moving through their sort of post-operative journey, and also a lot of weight onto what community services may be appropriate for them after discharge.
Okay. Is there anything you think, any other skills that you think make important for the neurosurgical nurses to have?
Yeah, so I think there's obviously personal attributes of skills, and there's also clinical skills. And certainly from the personal attributes, I think the most successful or the most sort of beneficial nurses that I've come across are very kind. And I think in paediatric neurosurgery, it's essential that nurses can have an excellent working relationship with both parents and also children. And it's important to be aware that parents behave in very different ways because of you know, the illness, which in many circumstances is life-threatening in their children, and it's just to be aware of the sort of heightened anxieties and to be able to reassure and allay the parents' concerns with regards to that. I think from a sort of clinical skills perspective, I rely very heavily on the nurses for the post-operative wound management. I think it's very important to encourage patients to depending on their age, obviously to feed, to mobilize, all of the things that prevent patients from getting post-operative complications such as chest infections. You know, and it's because the nurses are the ones who really spend all day with the patients and really deliver that care, is really just to sort of update the clinical team and especially escalate things early and to have the confidence to be able to do that. The other sort of clinical skills that I think would be very useful for nurses to develop is more of an understanding of the pathology that patients have, and also the anatomy, so that they can understand the operations that are occurring and what the potential complications may be for that, and to specifically watch out for those, be that from blood tests or the way that patients are and when they require specific scans.
Brilliant. And then what skills do you think we could give the nurse and staff to enhance their skill set and to keep them progressing as they become more senior within their neurosurgical role?
So I think, you know, to begin with, a good understanding of the anatomy and the physiology would be beneficial. And that also would then mean that the nurses are sort of more invested and they feel more confident answering patients' questions. Moving on, you know, with sort of escalating and going along with their career, I think other important things are to enhance their skills, be that venipuncture, especially in children, placing lines can be quite difficult, but also management of external ventricular drains is also a sort of essential skill for neurosurgical nurses.
Brilliant. Thank you very much.
You're welcome.
No, thank you.
Fabulous. And that was from Zoe in the UK. Alder Hay is in Liverpool in the UK. So I don't know if anybody has anything else they would like to come back and say from the audience about that. I saw that as talking about confidence in escalation, which is something that I think is very important.
Jenny, I think one thing that can be very important as far as facilitating communication, and there's a term we like to use with our team, regardless of the level, and the term is metrics. And metrics is kind of a global term that just refers to what are we measuring? What are we watching for? Like, for example, shining a bright light in the eyes of a patient that's having a paraparesis or a paraplegia but doesn't have a head injury mainly is useful as a motivate. So I would encourage anyone doing neurosurgical nursing to just be fairly deliberate in sharing with the team, okay, this is our shared patient. What are the metrics? What are the measurements that are most important for this team, for me, hour by hour watching this patient? Because sometimes they're standardized and they're written down on a sheet. So lots of patients get lights shined in their eyes and their sleep disturbed by doing so. And that adds very little value. Whereas those same resources, time, dedication could be sent to doing a more focused, tapered exam that's very meaningful and gives the team the things that they want. So ask about the metrics, be very deliberate and proactive in saying, what are the metrics? What are the measurements that are most helpful for this particular patient?
I think that's a really, really valid point, because I think it's very easy to get pulled into doing things as it is on a piece of paper, or in these days is on your computer, tick boxing things when it isn't applying the knowledge to this specific patient. So I think for your metrics, that comes through the team and your ability to be able to work as a team, but also comes from the education of the nurses, understanding the underlying problem and what our complications are likely to be, and encouraging the medical staff to say, okay, you know, where is your cutoff point? Where is your worry point? Exactly. What point do you want me to call you?
And sometimes these are clinical exam. Sometimes they're a drain, like an external drain. How much monitoring? You know, what if the monitoring? What if the output falls to, you know, just 2 cc's in an hour? Sometimes that's worrisome. Sometimes that's not. If the patient's bright and alert, well, probably not so worrisome. If it's a someone who's had a lot of output and is dependent on that output to maintain ICP control, then that's quite a worrisome finding. So I think just being deliberate and confidently but quietly proactive about defining what the key metrics are for those patients is really, really a good use of time and communication between the nurse and the team.
I quite agree. And Ahmed has said to us, what is our advice for non-cooperating patients? I think this, I assume that this, Ahmed, please answer a little bit more as well. But is this for examination? Is this going back to Ashley and Kathy's examinations with non-cooperating patients, or is this about neurosurgical nurses? Just if you could just type me another question as to who you would like to answer your question. We're very happy to answer it. Whilst you're doing that, Ahmed, maybe we could play one more.
Just to help on the question, Jeannie, the first is try to make a definition. What difficulty we have on this particular patient? Is a neurological question, is a consciousness trouble, or there is a behavior, only a personal difficult communication, or there is a language trouble? I think before the examination, we need to try to see what ambience we are, what kind of person is in front of me. It's with some kind of drugs, is somebody outside of the memory, outside of good communication. Is try to detect, at least with our observation or with family, try to see the real situation before to tell, yes, is a difficult patient or is difficult to examine. If it's difficult to examination now, if it's not urgent, just postpone a moment, maybe in half a moment or half an hour. It will be different in maybe not so noisy ambience, and we can get the answer that we are looking for. Just a compliment before the answer.
Fabulous, thank you. I agree with you. This comes down to one of the most important attributes and skills that we're talking about is communication, and that's communication between patients, between nurses, between doctors, between everybody, and understanding what's going on. If I can just come back to Ahmed. So Kathy and Ashley, Ahmed is asking for a few hints and tips on how to examine uncooperative patients in both a cranial nerve and a spinal nerve way. Do you have any quick hints and tips, Kathy, please?
I think it depends on their age. It also, if you can make it a game, that's a lot more fun. Get a flashlight toy, and use that, have them follow it, distract them. Distraction is great. Child life specialists are very helpful if you're having trouble getting a child to cooperate, especially if you're going to do something that scares them. Not examining them the minute you walk in the room, but sitting down, talking to the caretaker, talking to the child, letting them warm up to you a little bit. That helps in gaining some cooperation as well.
I think Ashley has also answered the question, but I can't actually see your answer on the feed, Ashley. Are you driving again?
Well, let me add just a little bit of thing, because what Dr. Ahmed has just mentioned is quite common in our setup as well. Many of our patients, especially pediatric patients, who are with their parents, and not only their parents, but there are a large number of attendees in our setup. In Pakistan, I think same with the setting in Afghanistan. There are so many attendants with a single patient. No matter how much you try, but it is you can say it's a tradition that everyone thinks that they need to go and support the patient's family. So sometimes it happens that our nurses report that that patient did not get the medicine you have asked us to inject or to give because they were not cooperative, and it is quite real. And at those times, sometimes a large fuss can be created. Sometimes even many patients are ready to fight with you because they think that it is not the right drug, and it is like that. So it is a very, very common problem in our setup as well, that the patients and the parents and the attendees and the attendants are so much non-cooperative. Sometimes you just what we do, we sometimes ask them to go to the doctor, to the duty doctor, and then we consult them and tell them the pros and cons and whatever they have in their mind why they are not cooperating. Sometimes it helps, but it is quite common. And the other point is we do have patients, obviously, like with the frontal lesions, who are quite aggressive, and those are the times which I think which are very challenging even for the nurses. In adult patients who are quite aggressive, you have to be very careful, because obviously you have to give them a drug, like we have to give them haloperidol, which is obviously quite it's essential, but it is very hard because they are not cooperating, and obviously they are quite aggressive, and it gets dangerous for the nurses to go there and get could give them the injection or something. So I think it is a scenario he has tried to create and just facilitating it, because we see it quite frequently in our setup as well.
Thank you. I'm going to put it out because we've just got the last few minutes. I just want to ask all of those people listening if they have anything else that they would like to question, if they have any burning questions they'd like to ask to any of the panelists, either about good neurosurgical nurse attributes, or if they want to talk about any of the examination. Does anybody else have any more questions? Whilst we're just waiting for people perhaps to type, I would just like to give a little thought to the fact that we will have the ISPN conference this year is in Chile in October. We will have a nursing day. We have had several very successful nursing days over the last few years. I am very aware of how expensive it is to get to Chile. And with this in mind, we are going to run a hybrid nursing day. Now, we would love to see as many of you who are out there come to the ISPN Nursing Conference in Chile. But it will also be hybrid, so you'll be able to, it'll be a Zoom, so you'll be able to present from home if you can't actually get to Chile. And I really would encourage people, abstract is still open. So please, please put your abstract in for anything that you have brought to your area recently. So maybe if you've done some research, maybe if you've brought in new protocols, new procedures, you've had a change of things that you would like to share with people about how you did it and what the impact was. Or if you've done any specific education that you want to share with us. We would love to see that. Abstract is still open, please pop it in. It's
yeah, but don't delay, because it's best to write them down and get them in, because I think May 2nd, which is just end of the weekish, is the deadline. So, you know,
it is. So we know that.
Yeah, better to get something down and in than to get something perfect that falls behind the deadline.
Absolutely, and we may in nursing be able to just squeeze out the because we won't have hundreds. We might be able to squeeze out the date a little bit longer. So please don't let the date put you off, guys. Get something in to me and let's start a communication and let's get lots and lots of people talking at the next conference. That's everything from me. Have we had any more questions? Yes. Oh, I'm having difficulty looking at it.
Jenny, while you're pulling that up again, I just want to compliment you and the other speakers. Everyone has given a really a good quality presentation today that's very thoughtful. So great, great content and a good job of moving back and forth to between the questions typed in, the videos, and the little didactic sessions. So well done.
Thank you so much. For me, it's been a really good session, and I hope other people have got something out of it as well. And we'd love people to send some feedback so that we can continue our education for nurses. What would you like to hear about? Anything else you'd like us to cover? And we'd love to be part of the of this session again.
One thing I can share that Nelsie and I have been talking about, we haven't finalized exactly. We may do a topic here circling back around to infection soon, and we're constructing a session on how to share your thoughts in a peer review process in a way that is organized enough to not be intimidating, right? Many times we see papers come in that have a good idea, that have a good amount of patience, but just as a result of not knowing the basics of how you present something like that, don't make it over the hurdle as far as peer review is concerned. And that's, of course, disappointing for a writer, an author, a team leader to have their paper not accepted, but it's also disappointing from the perspective of those that are reviewing the papers, because we want to get that experience out there, but it has to be done in a way where the study design is strong enough that we know that the conclusions, that the observations will have value just beyond your center. You see what I mean? If you follow the rules, then what's true in Maida Vale may be true in, South America. If we stray from those, then it ends up being just center specific observations. So there will be a session coming on that as well.
That'd be really lovely. I know we're just going over time. I wonder, Ashley, are you able to answer Ashley over the straight leg testing? I don't know whether you're still there, Ashley. And Diane has an extremely good point there. How do you build critical thinking in nursing? And this is one of the most important things, is that you have a nurse who can critically think for herself, who can work things through and can work through an escalation. And it would be very interesting, I think. I don't think we've got enough time to really explore this now, but it would be great actually to use that as a talking point at another session, how to build critical thinking in nursing. So Diane, thank you for bringing that up. I'm going to take that down, and hopefully we can use that again.
Thank you very much, Jeannie. Thanks for all the speakers and the audience. Just remind for those that would like to have the certificate, please fill the MCQs, and Linda will keep this webinar open for a while. You have time, just fill the questions. And the next webinar, usually on the last Friday of each month. And remind you that the new possibility, all the nurses can be ISPN members, just need the CV and 2 letters. If you need some support for it, just write to me, to Jenny or Jeffrey or Nora Maria. And also for the students, not necessarily professionals, you can join ISPN. And I hope can meet you all in Chile. Thank you very much. Thanks, Jeffrey.
Thank you,
Nora
Nelsie.
Maria.
Thank you, Jeffrey, and thank you, Linda. Thanks for coming, everybody.
Thank you so much.
Great session.
Thank you.
Zainab, you can submit your abstracts on the ISPN website. Thank you, Zainab.
It was a wonderful session. It was so nice to meet you all again. Thank you so much.
Hope you're getting better, Nora Maria.
Thank you, Linda, for facilitating.
You're welcome. Have a nice evening.
See you
For
soon.
the remain videos, Jeannie, did you believe that is important to put on the same recording or not?
Well, I think it would be quite nice to do that so that people can look at them if they want, because people put time into putting them together.
Linda, can you put the other videos in the same recording lectures, please?
Yeah, sure. I can add them on to the end. Maybe there should be a small introduction that it's like videos that haven't been discussed, or what do you think? For me, it's fine.